My name is Denise Rolark Barnes, and I'm publisher of the Washington Informer newspaper and a great big fan of DCPCA because I come here and I learn so much every year. It's just fantastic. So if you don't mind, join me again in congratulating them for bringing this forum to us. Now, we have a panelist, I think, who's really good at social media, and I've been tweeting all morning, and I said, what is the hashtag? I don't know. So I just asked my social media person at work to create a hashtag for us. Anybody out there do Twitter or anything? Because we need to tweet this out, let folks know what we're talking about. So we just created one, which was DCPCA 2013. So join me, because I feel lonely. I'm talking to myself out there. So join me, and let's let the world know, share this great information, let folks know that we're moving forward despite of what other folks are doing out there. So our panel now, we're talking about the importance of patient engagement and how quality impacts the patient experience. And I'm going to just briefly share some, some kind of set the stage. But I am going to ask Paige, where's Paige? Right there, yeah. Paige is supposed to really kind of help me out if I don't frame it properly. And so just listen out and make sure I'm on the right page, Paige. Okay, this session will build on the first panel and look at the importance of patient engagement and the patient experience in today's marketplace, in the patient-centered medical home, and in improving individual and population health. The panel will focus on what is meant by patient engagement and experience from the provider and consumer perspectives. We will also look at how groups are defining and applying the concepts in practice, and how healthcare providers and managed care organizations in the metropolitan Washington area and elsewhere are working to enhance engagement and experience. We also want to really talk about the challenges that are being faced and how individuals and organizations are overcoming them, and ways the patient engagement experience can be measured and linked to health improvement and reduce costs. Now, I just said a whole lot, but Paige, put it in perspective for us. What are we doing right now?
First, for a formal introduction, my name is Paige Cook. I'm the Manager of External Relations for the National Committee for Quality Assurance. My role is to help induct practices and large practice groups through our patient-centered medical home recognition program. NCQA is a nonprofit 501c3 organization that is dedicated to improving healthcare through measurement, transparency, and accountability. We have been known for being the quality measurement organization that accredits health plans. And back in 2008, we developed the first patient-centered medical home program that we are very excited to share. Has now crossed over 6,000 practices across the country. It's important to understand when you talk about patient-centered care that you're talking about the patient. And in terms of the way in which the programs have been designed, they have been designed with keeping the patient first. It's wonderful to hear organizations like Montefiore be referenced, considering that they were on our advisory board and one of our key participants that helped develop our ACO, our Accountable Care Organization Accreditation Program. NCQA is committed to including leaders in the industry in development of our performance measures and standards and guidelines for practices and health plans, and of course, clinicians that are operating them. With that being said, it's important to understand patient engagement is critical because education is key. If the patients do not know what the value is of matriculating or being a part of a medical home, they're not going to understand the value behind it. So in terms of the value of the medical home, it's focused on ensuring that the patient understands their role. When you talk about patient and protection ACA, which tends to fall off the title, the Accountable Care, or Patient and Protection ACA, it's important to understand that there are key components in terms of ensuring that the patient receives a care plan, ensuring that the patient understands the importance of medication management and that reconciliation when they're referred to a specialist, ensuring that they understand that their rights and responsibilities include being involved in the shared decision making when it comes to how their care is being delivered. So the Patient-Centered Medical Home Program provides a roadmap for providers to be able to follow a standardized way and methodology in order to interact with patients in the delivery system. And you're going to hear it over and over again that no practice can do it by themselves. It takes a community. It takes your pharmacist. It takes understanding that care is delivered in a team fashion and not just by the clinician that you see once a year for your health assessment. Understanding that behavioral health integration is important because those are part of your assessments in determining that you're going to be compliant with the medications that the doctor provides for you. So in short, you gave an excellent overview, and I'm happy to share more as we discuss on this panel.
Great. Okay, so now we're going to go and, before I get fired right on the spot for not introducing all of our panelists, but Paige was supposed to help me to kind of frame our discussion. So I'm going to go now and just introduce all of the panelists, and then we know we each have a few minutes to give some introductory statements, and then we'll get into our discussion. So the next person I'd like to just introduce is Deborah Deaver. Okay, and Deborah has over 40 years of experience in healthcare with 20 years in executive positions in a variety of settings, including acute care, home health care, rehabilitation, and primary care. She has a master's degree in nursing, service administration, and a bachelor's degree in nursing, and she has an extensive multicultural background, having lived in places like Mexico, India, Spain, and Israel. And she actually was the executive director of an award-winning, tribally funded federal qualified health center in northern Idaho. You have had some experiences. And she, at HealthWorks, now she oversees an organization that has cared for over 16,000 patients and has grown from a staff of 5 to 110. I need to talk to you about that. And now has 3 sites, including a new access point in Fairfax County. So we can welcome Deborah. I'm going to move now to Joanna Kaufman. And Joanna serves as a program information specialist at IPFCC, which is the Institute for Patient and Family-Centered Care. She brings more than 25 years of experience in inpatient and family-centered care. She's a registered nurse with a myriad of pediatrical clinical experience. And as a member of IPFCC's team, Joanna serves as a faculty member for the intensive training seminars. She actively participates in webinars and provides training and technical assistance to hospitals. She also manages social media communication, so you understand why I was trying to get that hashtag in there, social media communications for IPFCC. Let's now meet Phyllis Kay. And Phyllis serves as she's with the Regional Primary Care Coalition, and she serves as a director of that organization and an active collaboration and learning community, which brings together the region's primary care provider safety net providers, including DCPCA, and health philanthropy. With a background in negotiation, mediation, and community conflict resolution, much of her career has been devoted to strengthening community health services and systems, addressing the social and economic determinants of health and community engagement. She is a co-author of RPCC's Patient Engagement Framework paper. She's a Pew Health Policy Fellow at Boston University and holds an MPA from the University of Southern California and a BS from the New York State School of Industrial and Labor Relations at Cornell University. Next, Sydney Thompson. I'm ready to go to Hawaii. How about you? It's getting ready to get cold. Mr. Thompson has lived in the Shaw area since coming to D.C. in 1979. He's a former public interest lawyer and now a small business owner. He's a patient at Bread for the City. He's a patient with Bread for the, and he's on the Bread for the City board member. He entered Bread for the City's patient care system in 2007. He joined the board, the advisory board, in 2009, and the Board of Directors in 2012. Mr. Thompson has testified for Bread for the city at several public forums for low-income housing, health care funding, and public transportation issues for Washington, D.C. residents. Next, I'd like to introduce Mr. Ivan Walks, who is the Chief Medical Officer for Trusted Health Plan, former Director of the D.C. Department of Health, longtime supporter of Washington healthcare issues in the District of Columbia, and well-respected in the healthcare community. Let's give Mr. Walks a round of applause as well. And lastly, Angela Fullwood. Angela Fullwood Wood. Who is the, holds the MSW, and she's the Chief Operations Officer for Family and Medical Counseling Services. And Ms. Fullwood Wood received the MSW from Howard University. She's had experience designing and managing HIV prevention and treatment programs since 1992. She has considerable experience in the areas of program development and implementation, program evaluation, quality assurance, and training. And she is a nationally recognized trainer in the areas of HIV case management and HIV risk reduction for African Americans. She has been at the forefront of the creation of quality assurance standards for HIV/AIDS service providers. Let's give our whole panel a round of applause. Okay, we're going to start right to my left and then proceed down. So,
good afternoon, everyone. Thank you so much for having me. My name is Joanna Kaufman, and I'm a nurse. I'd like to address the issue of patient and family-centered care and patient engagement, and I have 3.5 minutes to talk to you. When Mr. Lazaro was saying, what is patient and family-centered care, I guess I'm going to sum it up. Patient and family-centered care is doing things with patients rather than to and for patients. And I'd like to have you keep that in your mind. The idea of patient and family-centered care is that patients and their family are active participants in developing their care plan, and that the conversation about patients and families and how they're going to address their care needs really encompasses a wide variety of things, not just their clinical diagnoses. I heard someone talk about compliance. The word compliance sets me on the edge, makes me want to jump out windows, makes me feel like, who's compliant? The reason that patients, quote, are not compliant is because nurses like myself and physicians make plans for them without having the input of the patient and their family. A patient won't have to be compliant if you sit together and you say to the patient, we want to have you get this medication. Do you have a pharmacist that can fill a medication? Can you afford it? Do you have a prescription plan? Can you get to the pharmacy? So the issue is not just whether or not someone will take their medication, but how it is that they actually get that medication. Do they know what that medication is for, et cetera? So when I talk to you about doing things with patients and families, you're starting to get the idea of what I mean. Another one of the tenets of patient and family-centered care is that the physician doesn't say what's the matter with you, but what matters to you. And again, I think that if we start to look at the idea of patient and family-centered care as having the patient be in the center of the care team, the one who drives the care, then we're starting to deal with patient family-centered care. I know I only have 2 more minutes, so I want to tell you a real quick story that hopefully will drive this home. A very good friend of mine has a daughter. Daughter's name is Suzanne. Suzanne is 9 years old, and Suzanne is very shy and is just now coming into her own. And about 6 months ago, Suzanne was diagnosed with juvenile diabetes. This requires that Suzanne test her urine, give herself insulin. And because Suzanne is shy and because she doesn't have a lot of friends, the idea of her getting up and leaving the classroom, going to the nurse's office, having to test her urine, and having to do that over and over and over is terrifying to her. When my friend Barbara took Suzanne to the pediatrician's office, the pediatrician laid out a plan, which included every hour Suzanne getting up, leaving, going to the lady room, doing this. And my friend Barbara said, But I don't want Suzanne to have to go through that. She's already struggling with who she is, and the pediatrician essentially said, well then, Suzanne's just going to be sick for the rest of her life. And my friend was appalled, and I suggested to her that maybe she find another physician. So with a lot of looking, she went to an endocrinologist who had a whole team, had a nutritionist, had a behavioralist, and the endocrinologist said to my friend Barbara, she said, Barbara, I am an expert in diabetes. I read all the journals. My nutritionist keeps up, will tell you all the latest things about the diet. She said, but you, Barbara, you are an expert on Suzanne and your family. And with your expertise and my expertise, together, we will put together that meets Suzanne's needs. So, patient and family-centered care. Thank you.
So when it comes to patient engagement, I'd like to talk to you a little bit about the value of standardization in the delivery of care, understanding that the patient-centered medical home model that NCQA has developed with the help of industry leaders has been designed in such a fashion that it provides, as I stated earlier, a roadmap. Understanding that in terms of the patient understanding what their rights and responsibilities are, it's up to the delivery system to educate them on that. And all of us are here to do that, to ensure that we achieve the triple aim. And we want to keep improving the patient experience as well as their outcomes in the forefront, understanding cost as a factor as well. But if you start with the patient first, the rest will follow. Understanding that in terms of how the provider interacts with the patient, how the care team interacts with the patient, understanding that they need to have that time where they actually are, again, provided a care plan, part of the shared decision-making process, ensuring that they are clear on their medications, but adding the importance of communication of those socioeconomic challenges that may prevent them from the self-care support that they need in between visits, and ensuring that they understand the value of understanding that your specialist needs to talk to your primary care doctor, and you need to have timely referral information in order to effectively coordinate their care. I'd like to share a case study in terms of my own personal experience and how care coordination has failed me personally. Understanding that my mother was diagnosed with cancer, uterine cancer, had her uterus removed. She said she didn't need it anymore, so she was okay with that. And then with that, there comes follow-up. It needs to ensure that she does the appropriate screenings, making sure that the cancer is not spread. And she also was dealing with a behavioral health condition that the primary care doctor nor the surgeon were aware of. Understanding that that would be part of a challenge in terms of going back for her routine screenings, ensuring that there's family that is involved in what her care process is, and making sure that she actually has someone at home who's ensuring she's doing her part. And at the end of the day, a year later, with a growth on her shoulder that literally got to the point where she almost looked like the Hunchback of Notre Dame, had been treated as an orthopedic injury by her primary care doctor, and there was no biopsy done, no reflection back on the fact that she just had a full hysterectomy, and the fact that by the time they did biopsy it, it was fully metastasized, and within a year she passed. This is an opportunity for all of us to look at some of the fundamentals of evidence that we have already in place and build on them. And what NCQA has done with the Patient-Centered Medical Home Program is to ensure that there is a set of guidelines. So I believe a question was asked earlier, how do I know to trust health grades? How do I know which provider to go see? One of the benefits of having a program that is nationally recognized, that is being used at the top systems in the country, is to understand that there is a value in that, and there are showing improved outcomes. And it could not have been explained more clearly that it's not just about the implementation, it's the application. So with that being said, when you see a seal that shows that this practice has taken efforts to commit to ensuring that they are delivering patient-centered care, that's step one. The recognition program is not the end-all be-all to ensuring that you're getting the care you deserve, but the way the guidelines are written, they have to educate the patient. They have to include them in their patient panels and councils when it comes to QI efforts. And lastly, they also have to ensure that the patients are educated and provided the community resources. Thank you.
Dr. Walks?
Good afternoon, everyone. You know, people always say it's a small world, and I always respond, it's a small world so the good people can find each other. And I think that that's true. This is just an incredible panel to be a part of, and I'm sitting here with new friends and old friends and good friends like Joanna and I have had a chance to sit down and share lunch. They fixed it, it was great. And I think that when people say, show me your friends and I'll tell you who you are, I think it matters. It matters who you sit down and have lunch with. It matters who you know. It matters who you've shared conversations with, and it matters who you agree with. And all of us in this room are here for a reason. We came here to share a day and share a meal and to understand each other better and to think about ways to work better with each other. I've done a lot of stuff in healthcare, in a lot of different places. One of the things I'm doing right now is being the Chief Medical Officer for Trusted Health Plan. Trusted Health Plan is new Medicaid HMO in Washington, D.C., and what are we doing with this whole idea about patient-centered and patient engagement and reaching out to people? Well, we have some really good ideas about that. We have such good ideas about that that when our case management and our other plans were submitted to the district, we got really high scores. We actually had the best plan. That's great. But we've heard a little bit about how you implement plans, and that's where, as they say, the rubber meets the road. And that's what we're doing now. We're out in the community where we have been for a while. We're working with the partners that we've met and that we're meeting, and we're understanding that this healthcare thing, it's a real personal thing. We just heard a really personal story. And when folks are willing to share that level of themselves with you, it means that something important is going on for them. Something important is going on in our community. One of the first things Trusted Health Plan did was to order our NCQA stuff because we want them to be friends too. Show me your friends, I'll tell you who they are. I mean, I'll tell you who you are. We want folks to know with whom we want to associate. We've put something together called Feet on the Street, where we have community folks from the community out in the community. I did a 2-year fellowship in transcultural psychiatry. I'm supposed to understand about how important it is to understand how people view what you're trying to talk to them about and do with them. And so that's part of what we do at Trusted Health Plan, is we try to get in there and help people guide us into the places where they're familiar and introduce us to the folks that they know that we want to know. One of our principles at Trusted Health Plan is if you touch us, we're going to touch you. That means that if you in any way touch the health plan, you're going to get something back. Thank you for the 1 minute. I'm really bad at time. But it also means that we did something different. People said, well, you have to have an opt-in or an opt-out program because when you go through these evaluations, NCQA, they're going to want to know what kind of program do you have. I said, we don't have an opt-in or an opt-out. You don't get to opt in and you decide whether or not we care about you. And you don't get to opt out and go join the rising risk pool and we don't ever hear about you. We won't come to your house if you tell us not to, but we will continue to reach out to you by any means necessary that are legal and reasonable because this is important. This healthcare stuff, whatever it is, matters. And I don't like healthcare. I sit on several different things. I sit on a federal futures group looking at healthcare, and we sit around and talk about all this stuff. We want to move from healthcare to health. We want to move from health to flourishing. We want to really talk about how do we build healthier communities and lead others down that path. So you want to work with us? We want to work with you. Time's up.
Well, my name is Deborah Deaver, and I'm the CEO of HealthWorks for Northern Virginia, formerly Loudoun Community Health Center. And one of the things I did want to mention is that my life has been so blessed right from the beginning. I think I had my first experience with patient engagement as a 6-year-old helping my mother with a flu epidemic in Teloapan, Mexico, where we were caring for patients in our own home. So my background goes back quite a long ways, but it has been very blessed with many different settings. I would like to know in the audience, how many are FQHCs or representing? Well, not as, okay. Well, for those of you, many, as you know, patient-centered medical home, patient-centered care has been part of our model of care for years and years and years. And so I may be preaching to the choir in terms of what we do at our health center. We are only not even 7 years old yet. And so one of the big challenges that we face is tremendous growth. So as they indicated, we started with a very low, very small, and now have 3 sites. I want to talk a little bit about the model in FQHC in terms of patient engagement, because one of the fundamentals for an FQHC is that you have a majority board members that are patients. So we're very fortunate that we have over 60% of our board members who are actually patients at our center, and who better to let you know if you're delivering the care, engaging the patient, and the services that you provide. We take it a step further in that we actually have board members also on our QI council, so they participate actively in that, and as you know, as board members, you're setting policy, get engaged in strategic planning, and really look at what you're doing to provide access in the community. So very blessed there with our health center and our board. I'd like to talk a little bit about our model of care. We are definitely team-based and have been from day one. We have teams that are color-coded, I guess, with 2 to 3, one team with 4 providers, a 2-to-1 ratio of nursing staff. So we have to every FTE provider. So we have a licensed nurse along with a medical assistant, hopefully with that ratio of 2-to-1. And we also have a patient care coordinator on every team. So the patient and their family, because we really like to think of ourselves as family-centered, does have excellent continuity of care because we always put them with their main provider. We actually allow slots, for example, on each provider's for same-day access sick visits. I can see we're going to run out of time very quickly. So what we do get in terms of feedback, we do use the obvious tools, i.e. the EMR, the portal, and have worked very hard to become a patient-centered medical home, as well as meaningful use, which force you to do what you're doing. But we also get a patient report card after every visit. We do QI surveys. We participate in our association outcome data so we can compare ourselves against other community health centers in Virginia. So we actually know our data and we can benchmark. We also do our own quality benchmarks and QI plan. Our QI committee includes patients. So we are trying to measure and share those outcomes and make a difference. And I'm going to really run out of time. So some of the challenges have been simply lack of resources. Our model is very difficult in terms of meeting productivity expectations, and the difference in cultures between Fairfax and Loudoun County, no transportation basically. So we have many, many challenges in 2 counties that you would feel that there should be better access when there's not. So I'll end there.
Good afternoon. Is my mic on? No. Okay. See, that's 30 seconds. My name is Angela Wood.
I want my time back.
And I'm with Family and Medical Counseling Service. And when we think about patient engagement for us in our model, it's about really 4 essential things. One is our outreach to other people and our ability to extend the first hand to engage you in care and services at our organization. And that could be through an HIV testing contact at the Department of Motor Vehicles, through one of our syringe exchange mobile units, or it could be in a testing event at the become maintenance center. But these are our attempts to invite, if you will, patients to come in and engage with us and see if we have services that can meet their needs. After that, I guess our second component is about efficiency, and the efficiency of engaging you in care means that we take that next step to link you to the services that we have in a quick and efficient way. In our model, we want you to come in the same day that we meet you, if it is at all possible. We understand that that doesn't mean that we can give you a full physical and meet all of your needs that day, but if we can at least begin to get to know each other in that first visit, get you connected to a provider, get you some initial lab work going on, that then we have a better chance of keeping you engaged with us. The other piece is that when you come back in is around appropriate assessment. The piece that we've heard all morning is people speaking about the need to look at both your behavioral health needs as well as your health needs. So we try to use combined assessments with our patients at that first contact, so we have a sense about what their true needs are as they begin to access care with us. And then it's about the patient experience, how good we treat you when you come through that door, from the person who greets you at the front desk to the physician who sees you and the social worker who provides care to you. And we put a lot of effort in trying to make sure that our staff understand that how we treat people has a direct impact on whether they come back, and in turn on whether or not they experience good, solid health outcomes. We are in the process now, we'll engage consumers at all levels, which includes as board members at our organizations, as members of our Consumer Advisory Board, and as participants on our Quality Improvement Committee. At this point, we're taking the next step, which is to train consumers as members of our team to go out and do some of our surveys, our client surveys, and as focus group facilitators, so that we get a true sense from our population as to how well we're meeting their needs. And that's in under 5 minutes.
Good afternoon. I'm approaching this from the patient, the one who needed the care. And I would have to say that Bread for the City had met all of those demands. Very quickly, I was working out at the gym, didn't feel well, went home that evening. The next morning I got up, something was wrong, went to see my primary care physician at Bread. She did EKG. After I talked to her, EKG, immediately to GW for presentment. When I got there in the emergency room, for 6 hours I sat there because I didn't meet the demographics that they were looking at as a black male over 50. Hypertension, high blood pressure, and a number of other things, probably drug addiction and those things. None of them. 6 hours later, the cardiologist comes to me and says, well, Mr. Thompson, things just aren't working out like we think. And I'm asking, what are those things? Well, you're supposed to have these things. Well, if you had asked me, you would have learned that I take my vitamins, I never eat salt, I do various other types of things, though I may be overweight and all of those things, I'm in good health. It makes sense now. 6 hours. Do you understand? 6 hours. But luckily, because of me not having those particular issues, 5 years later, my heart has rebuilt itself like it's supposed to, and I'm in good health. So part of my issue that I want to talk about is that the presentment problem is that there are certain things that they presume in demographics without confirmation. Okay? So that's one of the first things. And secondly, the patient has a problem a lot of times because they have the doctor is God syndrome. And I run into it a lot when I challenge the doctor, hey, I don't think so. And the doctor goes, excuse me, I need another doctor. And this is something that has to be the education process. Lack of education, when I say that, meaning that the lower the education level, the less likely they are to challenge the doctor on particular things. And I think it's important that we empower patients to be at least ask those questions. And it can be done respectfully, but it should be, the doctor should not feel that they're being challenged, quote unquote, about their authority, but challenged maybe in their perception. And that's where it's important. Everything is about perception. So I just want to say that in terms of teaching patients to value themselves enough so that they can look for the systems, meaning that the nurse comes in and does high blood pressure. Well, if the cuff's too tight, you're not going to get a proper reading. Ask for a bigger cuff. Now, I'm saying very simple things that can help make the process and the exchange much better. The other part is that nurses and doctors, and I'm very glad to hear what you were saying earlier as a RN, as a nurse, that the process is that you ask those questions, ask for their input. Sometimes people are fearful. They're sick. So you say to them, we understand that you're sick. Can you tell us a little bit more? What about your family history? I remember one time a doctor said to me, I want to give you some something for arthritic condition. My mother had osteoarthritis. And I said, no. Well, why not? I said, because it crippled my mother. I have the same DNA. No. But how many people are going to do those things? So I'm just saying to you that sometimes the patient needs to be encouraged to tell me a little bit more about you. I get really upset because everything is based on, because of the matter of money, you only have 1.3 seconds to talk to them about this and 2.3 seconds to talk about that. If they work it properly, that 5 minutes you spend with that patient will build trust, will develop a friendship, and you will help them achieve the goal that you want for them. And that's better health. Thank you.
That is, I think, what you were saying, and I'm Phyllis Kay with the Regional Primary Care Coalition. I'll get to that in a minute. I want to react because I thought what you said was so important, and what everybody else said was so important. Making sure that patients, consumers, whatever, have the information and are viewed as, by an organization, equal partners at a table. That may come naturally to some places. It may not come naturally to other places. So that when we talk about patient engagement, we are really talking about patients who are equal partners and viewed by equal partners of the organizations in which they are going to, who have the health, who are way ahead of everybody else, probably even, on health literacy, and understanding that what they know about themselves is important, and even if they communicate a little bit differently than a professional might expect, the listening and the communications is critical. And if we're really going to get engaged patients, which we believe, and this is sort of how RPCC got into it, are absolutely critical if we're really going to improve patient experience, which is, I think, narrower than patient engagement, if we're going to improve population health, and if we're going to lower cost, 3 elements of the Institutes for Healthcare Improvements, triple aim, of which the Regional Primary Care Coalition was a part, we have to get a handle on patient engagement. I want to, before I make a couple of other comments, thank DCPCA particularly, because RPCC picked on patient engagement as something to focus in within the triple aim work, because they said, hey, we can talk about lowering costs. We have don't always do it well, but we can kind of understand that. We know when it comes to improving population health, we're talking about social determinants as well as chronic conditions. But how do we get a handle? What can we learn? What can we do better when it comes to patient experience and engagement? That led us to say, okay, particularly looking at low-income populations who work primarily with safety net providers, because a lot of the patient engagement work has not been done in that environment. It's been done with other populations. It's been done in hospitals, but not primary care. So we set out, working with Terry Langston and Anup Hadbaran, who is a Princeton 55 fellow, and some other folks within IHI, to say, what is it? What does this patient engagement look like? And what I want to share with you quickly are 2 things. We see it both encompassing the clinical interactions with the healthcare system, which we talked about a lot today, but also community interactions with family, friends, neighbors, et cetera. And people, patients, consumers, whatever word you want to use, can become engaged at any point within the system. So we have done, I saw the minute sign, was to lay out a framework where people can look within the clinical interactions. Okay.
We'll call back a little bit later. Can't answer right now.
So, things that within the clinic that can be done. You heard a lot of that. I'm not going to deal with it. Partnering with patients, moving outside of the clinic setting, and so that people can feel within their whole lives they're owners of their own health, and they're engaged in population health. Some of the stuff, Angela, that you were talking about in terms of your patients and clients going into the community to learn more. I think we need to consider patient engagement as beyond the medical and healthcare setting and look at it in the community context as well, because that's how we're going to make progress. And our work is online, will be online, we'll link with DCPCA. Happy to answer questions. I'm out of time.
Okay.
Thank you.
Let's give our panelists a round of applause. Now, I'm not in the weeds of this, as you all know. I'm just a journalist. You know, I just write stories from a layman's perspective. But there's still a lot of questions that I have, and I want the audience also to ask, be acknowledged with the questions that you have, and we have about 10 minutes left. So I'd like to start with you, Dr. Walks, and just talk about how you are going to work with the community to try to build this concept of, you know, we're here to keep you well and not just to see you when you're sick.
Well, to be very practical, Trusted Health Plan is a managed care organization. If we don't focus on keeping you well, we go broke. So let's just, as they say, keep it real. So all of the incentives for a managed care organization's success goes in one of two directions. Either deny care for everything so you don't spend any money, or get people healthier so that you don't spend as much money in the wrong places. So for Trusted Health Plan, our approach is get in the community. We're opening over the next couple of months a community outreach center out in Ward 7, east of the river. It'll be a place where we're doing everything that you can imagine that makes sense, from haircuts to Marine Corps toys for tots. We are committed to doing what matters to the community, and that's where I think you don't engage people with what's important to you. You engage folks with what's important to them. And there are too many stories about people not understanding what happens in our community. When I was a kid, I lived on 39th and Western in South Central LA, and a lot of assumptions were made. I have a brother-in-law who died because people assumed that he drank. He didn't drink. He had pancreatic cancer. That's why his pancreas was messed up. He didn't drink. By the time they found out, he died. That's a common story in our community. It angers me, it hurts me, because we continue to do things like that. So, to answer the question, we're going to do it different. And we're going to document that we can do it different. I've been in the district for a while, and I know that in these same communities that we talk about, we can make profound, unbelievable changes. We heard about 80% reductions in HIV earlier. We have heard isolated incidences of excellence, and I think it has to be the norm. And so for us to reach out in the community, for us to have our administrative offices, have our outreach center, talk to our partners. One of the smartest people I know in healthcare in Washington, D.C. is Karen Dale, that works at AmeriHealth. Just, sorry, Trusted. I mean, it's important for us to partner in ways that are different than we've partnered before. And so I think that when I see Dr. Tilly Williams out there, who I've known for years, who we are reaching out to and we're partnering with, when I see the DC housing folks that we've already been talking with, this getting outside of whatever people think our lane is supposed to be, we are bad drivers. We are going to be all across the lines with everyone. And I don't have a set thing about how we're going to do things, because, my last point, if it was all figured out already, there wouldn't be any need for us to have meetings like this. We can figure it out together, and that's the approach that we're going to take. We want to work with who wants to work with us. Thank you.
Thank you. And that question came to me when I heard, Paige, you mentioned about patients understanding their rights and responsibilities. When I go into a physician's office now, are they going to give me like a sheet of paper that said, these are your rights and these are your responsibilities? As a patient, how do I know what those rights and responsibilities are?
Well, at the end of the day, when you're talking about providing culturally linguistic and appropriate services, you need to know your audience. You need to know your patient population and the best way to effectively communicate with them. So you can give them that information, but the dialogue is the most important. They can read it on their own, but you need to sell them on why they need to read it. They need to have an interaction that actually forms a relationship. So in terms of going into the office, understanding what it means when you induct a new patient into the practice, understanding what they should expect from this patient-centered medical home, and what they need, what their responsibilities are in terms of their level of communication. So it's about building the relationship. So my last point, because it's talked a lot, we've talked a bit about how do you capture the patient experience. And so one of the additional efforts that NCQA has made is to develop a distinction on top of the recognition status for patient experience reporting utilizing the CAPS PCMH. And with that being said, it's still under review. It can be very confusing with CG CAPS and several other CAPS surveys out there. And we're constantly evaluating the core measure set and ensuring that we are trying to make it more friendly for the patient that has to go through that 70-plus question survey. But at the end of the day, it's about the dialogue, not just handing them paper and making them read.
Okay. And Deborah, one more, and then I'll get to you. Deborah, you mentioned also about these patient report cards that you're asking folks to complete to give you feedback. Have they changed in any way that you've delivered any aspect of service? How have you responded to those?
We have majorly changed some of our systems based on that feedback. What we found that the encounter with the physician or the primary care provider and the nursing has not been the problem, but they have talked about wait. So we've done a major QI in terms of wait times and cycle times. Also, just our front desk and just reaching us through our communication system. We thought having a bilingual system, a group of individual staff that literally answer the phones one-on-one as opposed to going, or you can choose to go to the menu, still not getting through, still not getting their questions answered. So we've taken that as major QI projects in terms of really changing it, just based on these 5 questions that we ask the patient after they have their experience. So we were trying to gauge what their experience was like. We have, I just want to mention, identified a major challenge, and that's not only health literacy, but it's literacy, period. And so we used to emphasize and do a lot of education in terms of cultural competence and cultural sensitivity. This year, we are really looking at literacy. And part of that has been engaging in such programs as the Reach Out and Read. I encourage you to look at that. It's a wonderful opportunity to get the family and the child engaged and interested about reading. We have a reading corner in our waiting room. Now we're working on literacy as much, let alone getting to the health care literacy of our patient population.
Great. Let's take some questions from the audience. I know it's a question here.
Hello, I'm Nico Smith from Children's Hospital, and my question is actually to you. Miss Page, one of the questions that I have for you and some of the other panelists as well is when you talk about educating the parent, how are you working with your staff so each point the patient can be educated, whether they see the doctor, whether the front desk person can answer a question for them. That way everybody's on the same page and everybody can offer that same information to that patient no matter who's encountering that patient.
Just a little background. In terms of the patient-centered medical home model, it was built on the joint principles, which is actually focused on the pediatric community. What we did was we expanded it to encompass standards for the entire patient population, whether it be adult or pediatrics. And we continue to work with the AAP and ensuring that there are guidelines that include patients, include the family in terms, and caregivers, and changing the language about who needs to be involved in the process of managing the patient population. And lastly, I would say that in terms of the care team, the design of the care team, we emphasize using your care team to the maximum extent of their license. You need to ensure that those that are working within the practice are educated and trained to be able to provide different functions because, again, the clinician can't do it all by himself.
I'd like to also say two things. You know, one, leadership matters, so that the expectation of the leadership should be that everybody is singing the same song and that that message is getting across in the way that everybody understands. And the other thing I would suggest is if you're having this as an issue, maybe ask a few patients or parents to partner with you to help them tell your practice how it would be that that message could get across. That is one of the essence of patient family-centered care.
We have a question.
Thompson. My name is Gigi El-Bayoumi. I'm from the Rodham Institute. I'm both a doctor and from GW. So my statement is this. I am sorry for the experience that you had at GW. You were not treated well, and it is because, first of all, I'd like to think that it's an exception, but we have a problem in our healthcare system that everybody's alluded to, but I want to kind of bring it out and state it. The healthcare system is infected with a disease. It's called institutionalized racism and institutionalized classism. So I challenge all of us to make it an overt part of our discussion and not just alluding to it. Because really, when we look at Black women who are educated, highly educated with graduate and higher degrees, who come from upper class families, upper middle class families, and seek prenatal OBGYN care, their outcomes are still worse, okay? So that's all I'm gonna say, but I am sorry, and I'm glad that you're doing better.
Thank you.
I want to say that one of the things I did do is I did contact the administration and wrote them letters and then had interactions with them. So I don't have a real heavy contact, but I do have they know who I am.
Sure.
When you start using the unabridged dictionary, they pay attention. So, but the thing is that it is a dialogue, because it's not to be adversarial, but to say this is what I experienced, and we need to do something about it. And I think they've appreciated that from the administrative side, and then also the doctors themselves to let them know, I'm not here to argue with you in terms of, let's get into the struggle, but that we're here to do something. Help me. It's that type of thing. And I think when we make that, and I thank you for that much, but when we bring that bridge together and start flipping it a little bit more differently, we will eventually get to that point.
Great. Thank you. Your question.
Good afternoon. My name is Stephen Jefferson from the Stephen B. Jefferson Cancer Survivor Fund. My question is, I haven't heard anything about cancer in Ward 7 and Ward 8, east of the river, our part of town. We have the highest incident and mortality rate. So I'm asking you as panelists, how do you plan on engaging patients, survivors, and as far as educating those that are going through the struggle and those that are on the verge of going through the struggle?
Dr. Watts?
I'd love to respond to that. Thank you. To go back a little bit, I remember being in a meeting once where someone talked about how Ward 8 was in good shape because it had the lowest cancer rate, and I sat there listening, kind of struggling to understand, and it was brought home to me that people use statistics in some very ugly ways sometimes, and their stats had to do with age, and because Ward 8 had the highest rate of children, was the youngest ward, and most cancer is not in little kids. They were trying to use that, and it just made me very angry, and I've never forgotten that. And what we've done at Trusted Health Plan is we've gone out across the different wards in the district and looked at where those top illnesses, the diabetes, the heart disease, the cancer, the asthma, where are those? And how can we think differently about the interventions so that they are community and neighborhood specific? For example, maybe the high incidence of asthma isn't because, y'all just got bad asthma. Maybe it's because nobody is mowing the fields near your home, and so the allergens are, maybe there is no kept field, and so the dust is a problem, and maybe we can put air filters in homes as opposed to giving medication to people. There's so many opportunities for us to get into the community and look at how we as payers and we as providers can work together to learn more. There's beyond that. There's partnering the whole town and gown thing, the academics versus the community. We have reached out to, and I'm sure the other MCOs as well, have reached out across the academic community to those leaders in our communities like GW, like Howard, like Providence, like other places that are doing studies so we can learn more and understand more about how we can better partner with and then improve the health of our population. So I think that's sort of a rush because she's getting the sign. She had the sign just the sign was like this. Tired of her, but no, I'm kidding. And I appreciate you so much. Thank you.
So do I.
But what I'd love to do is to talk with you. You're actually sitting next to the trusted folks, are sitting right next to you. Talk with them about some specific ideas, and we just want to learn how to do our job best as we can. And so everything we can learn from everybody here is really what matters to us. Whatever. And I haven't talked about behavioral health at all, and I'm a psychiatrist. Sorry.
So we're really out of time, and I just got one of those in the back. So there's a lot of people giving us signals, but I just have one last question. Because we're talking about, our speaker earlier talked about, when you get older, you get sicker. So in the 65-year-olds, I have someone in my house that'll be turning that age in 2 days. Don't tell them that I told you. But yeah, we're joining that club. But what about those young people now that are aging out of their parents' insurance? They'll be 26, 27 years old. I'm not sick, I'll never get sick, I don't need doctors. How do we change that mindset so that we're not in the same place, 40 years from now? Anybody would like to just...
I guess one of the things I would like to say, it goes to peer-to-peer support. And I think that, when you're talking about patient engagement and patient interaction, that if you get a group of peers together and you put a little peer pressure on them, that's one way to start to engage folks who are under 65 to start to care about their health care.
The other thing we can do is to not make health different from everything else. I spent more than 5 years on the State Board of Education for the state of Maryland, and I think it's important for us to include health in everything we do. We can teach kids math by having them look at counting jacks and counting balls, and we can teach kids math by having them look at things that have to do with health. If we integrate health and positive health behaviors and attitudes into our normal everyday life and all the things we do, we have a much better opportunity.
All right, let's thank our panelists. Thank you very much.